Hi, I'm Dr. Jack West. I'm a medical oncologist and associate clinical professor at the City of Hope Comprehensive Cancer Center in the Los Angeles area. I'm also the founder and serve as president of GRACE, Global Resource for Advancing Cancer Education. Welcome to all of you, and I'm very happy to be joined today by two of my great colleagues who are also on the board of directors and longtime contributors to GRACE. I'll ask them just to introduce themselves and give a little background on where they're working, starting with my colleague, Jared.
Hi, I'm Jared Weiss. I'm the thoracic oncologist and clinical trialist at UNC Lineberger Comprehensive Cancer Center, and it's a privilege as well to be a volunteer and vice president at GRACE.
Excellent. And Ben Levy as well?
Hi, I'm Ben Levy. I'm an associate professor at Johns Hopkins and the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center, based out of Sibley Memorial Hospital in Washington, D.C. Like Jared, I'm a trialist and a thoracic oncologist, and I've been also privileged to be working for GRACE, and very privileged to be here working to discuss all things COVID for patients.
Excellent. So we're going to actually start with a focus on telemedicine. And this is a concept, a platform that we usually think of for video. It kind of can also be used to describe a telephone connection, but just remote delivery of medical information and care that has been around, at least as a concept, for many years. And we've had the hardware, we've generally had the bandwidth, and several companies and platforms to help make that happen for several years. But until very recently, I would say that it has been very underutilized. It's something that we kind of anticipated that we'll start to bring that into clinical practice, but then came coronavirus and the risk of infection and social distancing, people staying at home, and the desire now, or the need, to be way more judicious about even routine visits to the clinic. And it has forced us to step back and ask, does everybody who we have these visits with on a regular cadence of every few weeks or months really need to come in for a clinic visit on all of these occasions? And with that, we've seen the activation, the catalyzation of a rapid expansion of telemedicine happening really in real time. And at this point, I'm interested in input from both doctors Weiss and Levy about how they're actually using it at their centers, they and colleagues. I'll say that at my own center, we are really moving it out in real time. It's just at this point as a pilot that some of our docs are using more and more. We use a company, a platform called American Well, which is one of several that is tailor-made for this. But it's really a work in progress. And I think that we're going to have much more rapid adoption of this, not just by the core group of pilot pioneers in this, but broadly among our medical oncologists and maybe other physicians at City of Hope in the coming weeks to months. But I'm really interested in getting an idea of how it's being used or not used at your centers, folks. Jared, what do you think?
Sure. So I think everything that we do in medicine, and particularly perhaps in oncology, is a risk-benefit analysis, or sometimes risk-risk as reality presents itself. And for our patients and for us helping them to make decisions, we're faced with hard choices about the risk of COVID-19 versus the risk of cancer. And obviously not all of these choices will be made rationally, and not all of the time will there be one good choice. But in a way, if cancer is the rock and COVID-19 is the hard place, then virtual care, either through a telephone or video visit, is a good way for some patients to squeeze out between that figurative rock and the hard place. I personally feel quite strongly that when it's feasible There's something intangible and huge to the human connection of an in-person meeting, but we're not in ideal circumstances right now. And even before COVID-19, not all patients had the resources to travel as much as would be optimal to optimize their care. I've learned through this experience in doing video and phone consults that much as I still value the in-person, for plenty of patients, particularly when that relationship is already established, I think a video visit can get you a lot of the way there. And I personally feel that while a phone call can be the best option for patients without a video, without the internet bandwidth or computer savviness to do a video visit, I will admit, quite frankly, I don't think it's been quite as good. But to finally come around to asking the question you actually asked me, as an academic, I'm obliged to take at least 5 minutes to do that. In my section, in the thoracic and head and neck section at UNC, our policy is that every visit that can be a virtual visit now should be. And in fact, I'm requiring all of my faculty to document in their note why they were able to provide better care in person if they choose to do so. And I'm auditing every single clinical note looking for those, because we think that the threat of COVID-19 is so large that it's an ethical, humane, and medical imperative to do virtually everything that can be done virtually. Now, obviously, there are some hard conversations where patient and doc may choose together that the risk-benefit favors in person. There are some issues where you need a physical assessment. Obviously, if you're doing a CAT scan or an infusion, you can't do that over the phone. But whenever we believe that care can be adequately delivered at home, that in the moment is our preferred option quite strictly.
And Ben, how about at Hopkins and your whole network there?
Yeah, very similar approach as to what Jared alluded to at UNC. I think that we are in a rock and a hard place, and we have to make tough decisions regarding our face-to-face encounters with patients. This has moved out very quickly across our enterprise. Similarly to UNC, I think that there has to be a justification in this climate to see a patient in a face-to-face fashion. Obviously, if patients are getting treated or patients have scans, that is a certain scenario where we'll see them face-to-face. But outside of that, we are really trying to make every effort to see patients virtually. And this has really been facilitated by our EMR and Epic. Epic has a really nice function within it that allows these telemedicine visits to happen as you're in the patient's chart. We can consent patients through this video visit by sending them an attachment that they can sign and send back to us if we're talking about treatment. But every effort, I think, is being made to limit patients coming to the hospital. I will say that something that Jared touched upon that I think is important. What I have found is that these video visits seem to not interrupt care for that established patient. We know those patients, we've met them face-to-face. There's been this patient-doctor connection that's happened in a physical space. And there's something I think that goes down very differently within the walls of a room versus the walls of a virtual space. But for those patients, I think that's been harder, some challenges is in that initial consultation. And we at Hopkins are, again, really not justified in seeing initial consultations face-to-face at this time. We are doing a telemedicine visit as that initial consultation, even to discuss next steps as they relate to treatment, and even if it involves consenting a patient, which we will then send the consent form over the phone. So I think there is, maybe not the most ideal connection that we're trying to make with patients in these times, but certainly I think that we are in different times and a different climate right now, so we have to do that. So our policy is that every visit that, with some exception, should be done virtually, either by video or by telephone. I will tell you that the video visits seem to generate more discussion and connection, obviously, than the telephone visit does. We're in different times, and I think that it's an incredible, the rapid uptake we've had within our health systems. And I think a lot, again, this is facilitated by an EMR and a tech group within our hospital that has come around and allowed everyone to do this relatively seamlessly. The biggest pushback we've gotten more has been on the patient end. Patients are having a difficult time getting set up through MyChart Epic of getting this done. And now we've sent out videos on a how-to for the patient, which is making this a lot easier.
Well, I think there's a lot of points both of you raised. One is that it's not the same as being there. I mean, if we could, we would spend time, we would be doing this together in the same room. But the reality is that's not that feasible. I would, be able to, we would all want to hang out with each other and our families and friends, but we use FaceTime as something probably better than a phone call, but not as good as being in the same space together. And this too, I mean, this or a televisit is a lot better than nothing, probably a better version than just a phone call, but not quite the same thing as being there, but also acknowledging the reality that this saves people the travel, the parking, the being in a potentially crowded waiting room, and all of the exposures that people would have. And at this point, none of that is trivial. And so I think that's I think what we're all kind of saying.